care and services in public health. And I would really like to begin by introducing our presenters. It is wonderful to have Lisa Alguire here. She's a Bachelor of Science in Nursing degree grad and has been working in public health at Grey Bruce Public Health for the past 23 years. She has experience working in a variety of health promotion programs and services, as well as participating in the RNAO best practice guideline implementation and all the activities and planning since the organization became a BPSO in 2015. Also welcoming Cynthia Stone is a public health nurse with Grey Bruce Public Health, who became an RNAO best practice champion in July of 2025 and went on to become an RNAO best practice champion trainer. Congratulations, Cynthia. That's wonderful. Co-facilitating her first champions workshop in November of 2025. She's passionate about advancing organizational best practice and improving health outcomes for the vulnerable and marginalized populations. Thank you so much, Lisa and Cynthia. And we also are so excited to have Jody here. Jody Kaplan is a public health nurse at Grey Bruce Public Health with various program experience throughout 20 years in her career. She has been part of a practice change at GBPH since it has become a BPSO site in 2012 and was involved in the implementation of BPG and engagement through that. So thank you so much, Lisa, Cynthia, and Jody for being here. I am going to hand it over to you and we'll begin.
Great. Thank you, Julianne, for the introduction, and thank you to Andrea and the RNAO for giving us the opportunity to present today. So before our presentation begins, I would also like to acknowledge the long-standing history that has brought us to reside on the land that we speak from today in Grey Bruce. We acknowledge the traditional territory of the Anishinaabe Nation, the people of the Three Fires known as Ojibwe, Odawa, and Potawatomi nations, and further give thanks to the Chippewas of Saugeen and the Chippewa of Nehwashingaming, now known as the Saugeen Ojibwe Nation, the traditional keepers of this land. We recognize also the Métis Nation whose ancestors shared this land, and I am mindful of my own intention and commitment towards reconciliation, continuing to seek opportunities through my work and my personal space to learn and to better understand the history and culture that is part of the land that we reside, share, and sustain. So our region is comprised of Grey and Bruce counties, and we are located in southwestern Ontario, next to our First Nations communities and home to a number of Anabaptist communities. The objectives for today's presentation are to provide an overview of a public health approach to implementing TICAS, including key planning activities, strategies, and tools, to provide examples of program initiatives to achieve best practice recommendations and good practice statements, to share lessons learned, including early successes and implementation challenges, and to highlight how Grey Bruce Public Health is preparing for future evaluation. So as a BPSO, we are required to implement this BPG focusing on TICAS, which occurs when a person moves from one setting or sector where care of services are provided to another sector or setting. After taking time to review the results of 7 program gap analysis and careful consideration of how we can achieve the recommendations and good practice statements, we set an initial goal to implement 3 out of the 8, focusing primarily on 1, 3, and 5 across 7 programs. So this slide gives a broad overview of our approach. Our first TICAS meeting took place exactly 1 year ago in March 2025 to discuss implementing the best practice guideline throughout the organization to achieve best practice outcomes. This initial conversation took place with a small working group called our Nursing Practice and Leadership Committee, and we started to really explore what transitions in care truly means or doesn't mean within a public health context, providing some examples from different programs. From experience, we knew that applying a BPG in public health can be a challenge, and we must rethink the context to make it applicable for a public health setting. It had to be interpreted and applied in a way that aligned with our practice. So as the work started to progress, a TICAS implementation team was formally established to implement the BPG within each program. Another unique consideration in public health practice is the various roles of interdisciplinary professionals who work collaboratively to deliver programs and services, health promotion initiatives, and regulatory services. So staff have been engaged and knowledge translation has occurred in various ways since the beginning of implementation. Another approach was exploring the definition and the meaning of TICAS. During the early stage of implementation, our team recognized the importance of really taking the time to create a shared understanding of the definition. So since the beginning, 7 programs have participated in planning and implementation activities. And lastly, the success of this work couldn't be done without organizational leadership, strategic commitment, and the involvement of best practice champions. So what is TICAS and what does it mean for public health practice and who do we transition? These have been challenging questions, but foundational for understanding how TICAS can be applied in a public health setting to improve client outcomes. There are 3 main concepts that we have used to explore these questions. The first concept was using a population health and health promotion lens to apply the BPG within a public health context. The primary focus of this model is on key determinants of health responsible for disease and poor health outcomes. However, the model can be used from any perspective. So for us, this model has been really beneficial in exploring what strategies we use, how we use them, and with whom we interact with when transitioning clients. You can see on the slide, there are several examples of strategies that we use at the individual, family, community, sector system, and societal level. Through this process, we also recognized that a referral itself is at the individual level, but it can be part of a multi-level public health strategy when connected to upstream and population health actions. So for example, a public health nurse may refer a client to an OB clinic for prenatal care. When completing routine screening, the public health nurse identifies that the client is currently experiencing food insecurity and connects the client with local food supports. Over time, tracking these referrals helps provide data to inform community partnerships, that system-level planning, and policy decisions. So the second concept that helped us explore the question, what does TICAS mean for public health practice and who do we transition, was understanding who's your client. This diagram was created and published in 2017, outlining the various levels of client interactions within a public health setting. It was part of our work here at Grey Bruce Public Health implementing the Client-Centered Care BPG, which is now retitled People-Centered Care. In public health, the term client or person or people can be broadened to include both internal and external environments, as well as extend beyond the individual to include family, community, sector, system, and society. Understanding the definition of a public health client supports the application of that interdisciplinary practice, as well as the various roles of client interactions. As an example of internal clients, we think about our work directly with one another, such as information technologists and program assistants in our organization. They are part of the internal system that we know influences the external system. And the last concept that helped us to explore the challenging question, what does TICAS mean for public health practice and who do we transition, was using familiar language. So the results of our gap analysis that were completed by 7 different programs really supported our understanding of the definition and what TICAS means for public health. We really tried to examine and break down the language within the definition. So you can see from the template shown on the slide how we did break down the language of the definition. In public health, transitions do not always involve the actual act of moving a client from one setting to another. Programs such as Healthy Babies, Healthy Children may transition clients to other services or providers, but public health transitions are often broader in nature. They may include advising clients to access services, collaborating with other providers, supporting navigation of community resources, following up after referrals, and providing warm handoffs during outreach or inter-program work. Public health is also unique in the range of services provided, including assessments, screenings, care coordination, investigations, contact tracing, enforcement, shared protocols, and system-level responses. As such, transitions in care in public health requires a flexible and inclusive understanding. And again, we know that sometimes public health transitions occur internally, so we continue to include both internal and external environments to capture some of that inter-program work.
Thanks, Lisa. So to set the stage for incorporating TICAS best practices into Grey Bruce public health programs and services, we wanted to reinvigorate staff and get them excited again about PPSO work. During May, we hosted an RNAO open house to really plant the seed for this work and provide staff with the opportunity to have fun and explore what transitions in care means to their public health work in a creative way through art. This event inspired some to join the already formed BPG implementation team. An RNAO Champions training was also held in November of 2025 at the Health Unit, again to build staff's confidence and toolbox to becoming champions within their program teams and to incorporate and move TICAS work forward in their teams. This champion training day also gave teams opportunities to brainstorm, and it really was the inception to many of the implementation plans. Next slide. So this slide is a visual of the general process teams underwent within their smaller groups. And it's important to note that some of these steps were in tandem with organizational activities to build the momentum of this work. So teams dissected the definition of BPG to think about what it means to their work. And Lisa's table a few slides ago really supported this step. We looked at what activities were being done in our program areas and opportunities for improvement. And this helped us to identify the change initiatives and build implementation plans on that. And we recognize the importance to consider indicators at this stage, particularly the Inquiry Data Dictionary, to help measure the change. And lastly, we had to think about our partners who would be involved with these activities and how we were going to engage them for some success. Next slide. So here you'll see on this chart the programs within the health unit that have engaged in this work, and the recommendations or good practice statements that will help guide them. And this was really helpful for our implementation team to see high level where there were alignments with the BPGs and BPSs. So I'm a nurse on the school health team. So exploring our implementation plan a little further, we identified the importance of integrating good practice statement 5.0 in the support we provide to students and their support networks at secondary schools, following a Smoke Free Ontario Act or SFOA infraction. So good practice statement 5.0 in this BPG looks at its good practice for health and social service providers to provide persons and their support networks with information and support to manage their needs during and after transitions in care. So when an SFOA infraction occurs at a secondary school, students are generally suspended depending on school policy and that infraction is reported to our tobacco enforcement officers, or TEOs. From there, the TEOs meet with the students, they review legislation, their enforcement rules, and they discuss options. And one of these options could be referring that student to a public health nurse that works in the school to help support that student and manage their substance use needs. Each of these transitions from both a student and support network bring with them different emotions and questions. So this BPSO reinforces the importance of providing information and support to manage those needs and uncertainties. So in collaboration with the TEOs, we've developed physical resources to share with youth and their support networks during each transition, resources to support parents and guardians on having supportive conversations with their youth are provided with the suspension orders, and community and social supports are provided by the TEOs, and one-to-one support and resources are provided by the school PHN with the student, again, based on their needs. So looking at one evaluation measure for this initiative and aligning it with the NCLIRE Data Dictionary, we plan to collect the number of resources provided at each transition and the number of referrals sent to public health nurses to meet with students and compare them to the total number of SFOA reports in total made to public health. So through this integration of the PPS 5.0 into our work, we hope that support networks and youth feel supported regardless of their stage of change they're in, and that they feel engaged and in the driver's seats of their care. This work also leads with a trauma-informed and health equity approach to care and honoring person autonomy. Next slide.
Thank you, Jody, for setting the stage of what implementation planning looks like within the school health program. We're going to shift now and look at the infectious disease and sexual health program. And these next two slides are quite information dense, and each of our programs could really do a whole presentation just on the implementation plans. So I will be presenting only some key highlights from our plan, and for more details, please read through the slides and feel free to reach out to any of us today. So from our ID and sexual health gap opportunity analysis, we concluded our areas of focus for TICAS would include good practice statements 1.0 and 3.0. And to review what good practice statement 1.0 is, you'll see it referenced at the bottom of the slide. It is good practice that health and social service providers collaborate with persons and their support network before, during, and after a transition in care in order to ensure a safe and effective transition. In reflection of Statement 1.0 and considering our identified gaps, we harness the opportunity to improve collaboration with our clients through engagement with their support network. So just for some background context, in our ID and sexual health work, we are often in conversations with clients that involve a lot of health teaching. And when we call a person in the community, it may be the first time that they're hearing about their diagnosis. It could be a life-changing diagnosis like HIV, or other significant diagnoses like active tuberculosis or invasive group A strep, where a person could greatly benefit from having a member of their support network present. Given it can be very difficult to take in educational information if you're also trying to process a diagnosis. So for our desired practice change, we decided we would create a people-centered practice for phone calls involving new diagnoses or exchange of significant health information. And people would be routinely asked if they wish to include a member of their support network during the call. We updated all ID and sexual health organizational investigation forms to document when a person wanted a member of their support network present, that we obtained consent, and we would also enter when a person elected to have a member present into an Excel log for tracking purposes. We felt we would be able to easily implement Statement 1.0 and have high impact outcomes at the same time. So for us, Statement 1.0 was a quick win endeavor. With respect to evaluation indicators, we would audit the BPSO Excel log. We would perform random chart audits to monitor our progress of when people chose to have their support network present. And we would also ensure that consent was obtained for this process. We considered our desired results and outcomes to include people feeling more supported and engaged in their care, that trust and collaboration would be strengthened with people, their support network, and with public health, and that this plan would represent a health equity approach and reduce disparities for vulnerable or marginalized groups by having a supportive network present of their choosing, who will advocate on their behalf when they may not be able to. In terms of some other notes and reflections during this process, we felt this approach respects an individual's autonomy and their preferences, and it supports shared decision-making and engagement in care planning. It builds in a trauma-informed approach by promoting choice and control, emotional safety, and by encouraging collaboration. And finally, we felt this was a culturally safe option by reducing power imbalance and allowing the person to decide what feels safe for them. So moving to the next slide, here we are focused on Good Practice Statement 3.0. And again, to review the statement at the bottom of the screen, it is good practice that members of the interprofessional team collaborate to develop a transition plan that supports the unique needs of persons and their support network. So again, just to provide a bit of background, one of the issues that the ID and sexual health team identified over time was that healthcare providers had differing levels of expertise to identify and respond with the correct staging of syphilis. And therefore, some people diagnosed with syphilis were at risk of having an ineffective treatment course. To engage our interprofessional team, we decided the aim of our desired practice change would be to develop a streamlined, mandatory syphilis reporting form for healthcare providers to complete and promote evidence-based staging and effective syphilis treatment. Unlike Statement 1.0, Good Practice Statement was not considered to be that quick win. It would take considerable time to implement and would also have high impact. It's nice to think about the balance of good practice statements when you're choosing which one you're going to go with. And if you are picking more than one, it's nice to have that balance of the quick win with the longer implementation. It's also important to consider whether or not your outcome is of high or low impact and prioritizing the high impact. In terms of organizational and procedure changes, the ID and sexual health team completed multiple rounds of design for a new healthcare provider reporting form. This form is a comprehensive document and includes syphilis staging, signs and symptoms, evidence-based care plans for syphilis management. For ID and sexual health's desired results and outcomes, they include increasing the accuracy in syphilis staging across cases, appropriate and timely treatment of people, reduction in the secondary of transmission of syphilis in the community, and strengthened communications and transitions with healthcare providers. And finally, we include some notes and reflections and feel in this plan we are integrating a user-friendly, standardized form into healthcare provider workflow to guide healthcare providers in staging and reporting and mandating documentation of healthcare provider staging and their rationale. This will help flag any uncertainties for public health and prompt follow-up for consultation. We will provide healthcare provider education and real-time support to enhance understanding and reduce treatment errors. And we are employing an equity and people-centered we are employing both equity and people-centered principles to ensure a standardized process and access to quality treatment to help meet the needs of all populations. So moving on to the next slide, with respect to lessons learned, absolutely, making it meaningful and relevant to individual programs we felt very important. And it may help to ground the work within the public health core competencies. So, for example, our communication competency highlights the importance of communicating evidence to inform options for policies, programs, services, and practice. And the TICAS work that we're doing here helps support personal development under this competency. Another lesson learned was to brainstorm and support each other. So as best practice guideline interdisciplinary and program teams, we really relied on each other to try to walk through and talk how we could see this best practice guideline applied to our individual programs. Another lesson would be not to get discouraged. Know that the application to public health practice will take some time, and likely you'll have several rounds of adapting one good practice statement to your program. And know that program prioritization for recommendations, good practice statements may change. You may switch from one good practice statement to another. Keep staff engaged and foster an understanding of the work and roles of the staff. So you'll see here on the slide that to the left, we have published our TICAS work in our internal newsletter. And this is a way of informing our BPG champions and staff of some of the innovative contributions of our implementation efforts. And finally, reaching out as you need to your RNAO BPSO coach and internal leads was really important for us. And in terms of next steps for our implementation journey of RNAO's transitions in care and service best practice guideline, we will continue with our PDSA cycles of implementation, evaluating and monitoring our key indicators to assess impact and sustainability. We'll participate in ongoing staff engagement, development, and facilitating knowledge translation of TICAS into daily practice. We'll celebrate our successes along the way through knowledge dissemination with our staff and other public health BPSOs to promote, spread, and scale. And finally, we will take time to enjoy the process with our clients, support networks, community partners, and internal RNAO champions to foster strong relationships and build capacity. So in our final slide, we just would like to say thank you for your attention today, taking the time out of your busy day to come to our presentation. And thank you to my colleagues, Jody and Lisa, for their insightful contributions to this presentation. And speaking of enjoying the process, this photo here shows all the lovely faces behind the implementation work of TICAS at Grey Bruce, and a photo from our Champions Workshop, November last year. We would like to extend as well a special thank you to every one of our BPSO champions, as well as our BPSO coach, Sabrina Morale, shout out to you, and our BPSO lead at Grey Bruce Public Health, Janet Kwanzaa, for helping us to lead in this effort. Thank you for your time.
Wow, thank you so much. Thank you very much, Lisa, Cynthia, and Jody, for sharing about transitions in care and services and how it relates to public health. There is so much to learn from all the success your team has achieved. And it was very interesting on the journey you took us through really looking into that guideline and how that works in public health and just some outstanding results. So congratulations to your team on that. If we have time, we have some time for questions, which is wonderful. And I do have a question here. And thanks for this picture of your champions. That's just amazing there. And this is a question regarding your champions workshop that you had mentioned. So